Let's see. So my name is, again, Barry DeCoster. I'm a philosopher who works at the Albany College of Pharmacy and Health Sciences. So Albany, New York is about 3 hours north of New York City in upstate New York. I'm part of the Population Health Sciences Department. So this is what houses our undergraduate public health program, which I was hired to teach in. But I'm also at a pharmacy school, and I spend a lot of time working and teaching pharmacy pharmacists. And it's been an interesting thing for me to think how pharmacists have engaged this pandemic, what their clinical response is. I've had over my career the ability to teach MDs and DOs and nurses and veterinarians. This has been my first sort of last 7 or 8 years working with pharmacists specifically. And it's an interesting experience to see how they engage the world differently with different questions, different tools. Also, it's kind of come up that this word hydroxychloroquine took me, I don't know, maybe 2 or 3 weeks to figure out how to spell and pronounce properly. And I think my students fully enjoyed watching me stumble on this in the way that they were awkward when trying to sort of properly pronounce deontology or these other words that I was throwing at them, that's jargon. They were ready to sort of engage and sort of see me stumble on their specialized words. Let's see. So with that, the work that I'm going to talk here in part comes from a teaching case that I've developed with a former student. Also will be, as we know, I should probably note here, just deeply focused on the United States and sort of my experiences and sort of watching the pharmacists here, especially in upstate New York. So with that, as we've already started to understand, right, there's been a lot of discussion about this drug, hydroxychloroquine. So it's sold under a number of different names. Plaquenil is one. And so this drug, I think most of us had never heard of maybe 2-3 years ago, but now it seems to have been in the news and much politicized. It has been traditionally used and developed in the 1950s as a treatment for malaria. And some of this is what Tina has already pointed out, right? There's this history of this been kind of complicated in the last year around this drug. So we had an anti-inflammatory drug here treating, again, malaria, lupus, rheumatoid arthritis. It's small, it's an oral medication. It's taken in a number of situations. It's been, although it has side effects, it's relatively understood as safe. Yet in last March and April, it became kind of internationally understood and talked about in some interesting ways. What I want to talk about is the way pharmacists had to respond appropriately to this new engagement of this drug. It ultimately was found to be not effective in preventing or treating COVID-19, but right, that was controversial for a long time. So if you will indulge me to set up the case, I just wanted to kind of lay out a quick broken timeline here. I'll go back and forth a little bit. I want to hit a number of major points about national and international discussions around how hydroxychloroquine got brought into conversations. So Raoul's in March 17th published a paper with his colleagues suggesting that hydroxychloroquine plus a Z-Pak, right, an antibiotic package of azithromycin, may be effective in treating COVID-19. So in the US, later that evening, Dr. Anthony Fauci had appeared on TV already being questioned about the importance and the sort of way this one scientific paper kind of got hyped and sort of after Trump's retweeting, how this paper got legs, how it became sort of widely discussed. Fauci was hopeful, but I would say ultimately hesitant about sort of using too much his language of anecdotal evidence or relying too much on any one scientific paper in order to sort of promote or overestimate possible treatments here. In March 28th of 2020, the FDA ultimately approved the emergency use of hydroxychloroquine and sort of studies around for its use around COVID. Later that month, the next month though, in April 22, right, all the sort of pushback had started on Raoul's paper, the criticisms, apart from also its publishing organization, but worries about randomization, clinical trial size, right? So it was quick to sort of gain traction and also kind of quick to gain a kind of controversy, public controversy that I think is atypical for most scientific papers. So that is sort of mid to late March. In early April, there was a Sunday news conference around COVID, the White House COVID response team. And in that, there was a question directed originally at Anthony Fauci. President Trump at that moment sort of stepped in, as he was wont to do, and sort of responded in his own way. I'm a little hesitant in sort of pulling too much useful information out of Trump, except just to set the context here, right? There's a lot of kind of word salad. But one of the interesting things that I think, if I want to be overly generous to his discussion here, was to say there was this hope that hydroxychloroquine would be known as a already understood, already manufactured drug. It had been useful in treating other diseases, in that there was the possibility, of the sort of scientific possibility, that this could become useful in clinical settings. The second paragraph is where he kind of both, does a double speak of sort of pulling back and also pushing forward, saying, well, it'd be great if this worked. We'd love to have all the time in the world to do more clinical trials. We don't have that kind of clinical time since people are dying. So we have to sort of just trust him and say that this is an interesting response. And probably we've all been done that, or heard parts of those stories there. In later March, the American Medical Association warned against the overuse and reliance on hydroxychloroquine. In May, Trump announced that he himself had been taking hydroxychloroquine for about a week and a half once he got sick, and he'd had zero symptoms, right? And then his other thing is like, what do you have to lose? He, in that moment was saying, I didn't have symptoms or negative side effects, so everybody might as well sort of engage with this. Also, the VA, which had put out a report questioning the efficacy of it, when Trump himself sort of criticized the trial as being, or the paper as being very unscientific. And then by mid-June, the FDA had revoked its emergency authorization use for hydroxychloroquine. So that doesn't quite end the story either, right? I just want to point this out. A year later, we still have interesting little ripple effects that I think we're still dealing with this drug and its hyper-focused and hyper-promoted possibilities. So here in the States, the state of Oklahoma had over $2 million worth of the drug stockpiled from a private manufacturer. The governor of the state told in an interview, the AP, that the stockpile had happened, and I like this phrase, in the fog of war, right? So this is a kind of justification for why the state had put so much money into buying hydroxychloroquine, and defended it, saying, well, we have way too much of it, but we're going to use it eventually, on other uses such as lupus. The other interesting thing for me was just late last month, Secretary Ben Carson, who had been part of the Trump cabinet, himself a physician, a neurosurgeon, had promoted, yet most recently here in 2021, saying that the benefits of hydroxychloroquine, he connected it to rates of malaria in Africa, saying and also that we needed to study why African nations were having lower COVID rates, but also that there are still sort of scientific benefits, and that he himself was sort of behind this drug. So there's a weird way in which, even what Tina was talking about prior, there was misinformation, but it's got a long-lasting kind of legacy in a number of moments. So for me, what I'm interested here is thinking through what has the work and impact on pharmacy been, and how should we think this through? So one of the things I'm interested in about how pharmacists work in the world is saying that they still needed to sort of fill prescriptions and respond, right? In a moment under COVID, it was an atypical experience for them in many ways. They had very limited clinical data to draw from, right? The pandemic was facing new challenges that we had some data for, but it was ultimately, a new experience. The pharmacists I work with are nothing if not diligent in the way that they look back on understanding how a drug works. They want to know all the details. They're very conscientious on this stuff. The details matter in a way that is amazing to me, and they can kind of keep the cost-benefit analysis of these things in mind in a way that goes much further beyond what most physicians are able to do. So physicians here were prescribing hydroxychloroquine pharmacists had the question of, do we need to fill these prescriptions and why? So they were working on limited or at least conflicting clinical evidence. There was the general sense of fear in the world that we were responding to a global pandemic. They themselves had family members or themselves were being exposed on a regular basis in hospitals. There was an urgency coming from patients themselves, right? The sort of fear of what would protect us. And then the general topic itself of COVID responses and hydroxychloroquine as a specific drug had itself become politicized. So in that way, I would say pharmacists were reacting in an atypical situation, right? The sort of fear, the lack of information, and the polarization or politicization of their cases was important. So with that, I was working with students, and I've developed this semi-fictional case response, right? It sort of has some threads that are in the real world with plenty of things changed to preserve anonymity. And here I want to give acknowledgement to a former student of mine, Record Bodo, for creating this case with me. So in this case, Jill, a junior pharmacist who's still on her rotations in the early days of the COVID response. So think late March, early April in upstate New York. She's asked to review an atypical prescription for hydroxychloroquine and azithromycin as a combination prescription. The prescription catches her eye as atypical, and she also notices that it's been recently discussed in the news, including by President Trump, as a COVID prevention mechanism. The pharmacist, after consulting with her superior, her supervisor on call, calls the physician, the prescribing physician, who happened to be a radiologist, to inquire what this is meant to treat. After that conversation, which we'll unpack in a few minutes, the pharmacist declines to fill the prescription. So in this moment, I've been wondering, was the pharmacist in this case actually right to not fill a prescription? And if so, on what basis? And in pharmacy blog land, there were cases like this all over the place. Pharmacists were all of a sudden being asked to repeatedly fill these hydroxychloroquine and azithromycin prescriptions. I myself kind of half wondered if I should be getting one filled for my elderly parents who are up in Maine, since I had access to enough pharmacists, or sort of what sort of fear had motivated me to do this. But also the case here is really around what kind of ethical and professional response should pharmacists have in filling such a prescription. So with that, I think ultimately she was right not to fill it, and I'll ultimately give 3 different arguments for why that was. Generally though, pharmacists have the right not to fill prescriptions and rarely do under a number of normal circumstances. So the way in which a pharmacist can refuse to fill a prescription, the most frequent one, somehow there's a technicality in that the prescription itself is invalid. Often this may mean, say, the date for which it should have been filled is long since passed, or that perhaps in some moments the prescription somehow didn't have a name associated with it. It's rare. In the US, there's typically only one moment where a prescription can be filled without the patient's name on the prescription itself, and that's with anonymous expedited partner therapy, a way to hand out antibiotics in treating sexually transmitted diseases, something I've written a little bit myself. But in this case, the pharmacist had a name on the prescription to be filled. Other reasons not to fill might include, say, ultimately patient safety issues. So that could be, say, the dosage itself is too high and thus becomes unsafe. There might be interactions with this medication with other medications, and it's this pharmacist's job ultimately to check what this patient is taking on a regular basis and look for possible interactions that may put the patient at risk. There are also conscientious objection clauses in many states in the United States. So this, you might think about, pharmacists may have the right to not fill a prescription based on their own moral standing. And the big examples in the US have been emergency contraception. And then in the last year or two, it's become a lot more public, some controversial cases around not filling prescriptions intended for trans patient care. These objections are written into sort of state law. They vary state by state. often they have some sort of patient protection clause built in there where the patient, if you're not going to fill the prescription for this patient, the pharmacist is required to support the patient and help them get it filled somewhere else. But that isn't the case in all states. The final moment that is not quite, it's somewhere in the middle there between filling and not filling, is a delayed filling. Often pharmacists will make suggestions, alternatives to either the patient, the physician who is prescribing, or both of them in that moment. Sometimes this is to address, say, side effects issues and make sure people understand, like, they understand what is likely to happen here and are they willing to engage it. Or if the cost is somehow prohibitive, there may be a modified prescription that they could fill that would be much more reasonable for the patient to be able to pay for. These are the sort of most frequent reasons to not fill a prescription. I was just pointing them out here to say these are not what's happening in the case of Jill, the student pharmacist in the case before. So here's what I would say is 3 of the biggest appropriate issues for what Jill might have used to not fill the prescription in this. One is this was an off-label use. This is not uncommon in medicine, but it does put the pharmacist in an interesting role here. So when it came to hydroxychloroquine, especially, the New York Times ran a number of moments. Let's see, the American Medical Association had its own discussion here too about whether or not pharmacists should have any role in determining the appropriateness of the use of hydroxychloroquine as an off-label use drug. Many physicians actually argue that this is a moment where pharmacists have no role, no clinical judgment role in it, that this is a decision best left between a doctor and a patient. In these moments, I've argued to them that pharmacists often do a number of different kinds of work that it goes under discussed, I would say, in most medicine. Lots of bioethics rarely ever talks about pharmacists' work here. One is sort of navigating carefully that doctor-patient relationship. The people I work with, the pharmacists who I'm teaching, they're really aware that their job is to support that doctor-patient relationship, ultimately, and help that to flourish. So they're, even when they disagree, they're very, very careful and thoughtful about how to engage, how to give alternatives, but let that doctor-patient relationship remain fruitful, and also how to support the patient in ultimately making their decisions here. The other issue here is that pharmacists are actually usually better on their game about the details of interactions and possible side effects of all these medications. So I guess one thing I've learned is while working here is if you have questions about your medicine, get to know your pharmacist really well. They're often very good about being able to describe the sort of clinical and embodied experiences of taking medications and what side effects may be possible, how to work around them. So here there's an epistemic role for pharmacists as well, of trying to figure out what is the known health worries and benefits of a certain medication and how to balance them with off-label possible uses of a medication. And finally, the third piece of work that pharmacists do regularly and do very well is an educational component. They would call it counseling of the patient, but really they are in the driver's seat trying to teach the patient when the patient wants to understand the medication in front of them, what is best for them, and what their alternatives are. So they are very good about helping patients kind of finish that informed consent process, right? They're really useful in this sort of informed component of understanding, can they ultimately, should a patient ultimately want to take a medication and for why? Now, with off-label uses of hydroxychloroquine, specifically in early 2020, prior to March, most states had no sort of language on this, right? Because it was a standard treatment for rheumatoid arthritis and lupus here. The documentation started to be required, though, state by state in a number of moments, where if people were going to prescribe hydroxychloroquine for a COVID situation, that COVID diagnosis had to be indicated on the prescription itself. So you couldn't just be sort of prescribing hydroxychloroquine without a reason why. And also, there are a number of states put in new policies saying, excuse me, because this drug was of a limited supply, the new prescriptions could only be filled for a 14-day supply. You could not have sort of an ongoing prescription for hydroxychloroquine. Okay. The second, more interesting, or very interesting to me, word about hydroxychloroquine was at this moment saying that the scope of practice had to be understood here. Ooh, I'm hitting my time period, aren't I?
Yeah, I just wanted to say your time is pushing up. Yeah.
Okay, I'll quickly get through this. So the second reason in this case that scope became an issue was scope of practice. Because the prescribing physician here was a radiologist, the pharmacist was right in many ways to question this prescription, in part because there was no reasonable way in which the radiologist patient was directly being impacted qua radiologist here. Right? So there was some other issue going on here. If had this been a pulmonologist, the prescription may have been filled appropriately. And the scope of practice language is interesting in that it largely relies on professional judgment language. Most state and clinical codes of ethics require again, the professional judgment of the pharmacist to make these decisions. And then the third issue here was to say the pharmacist here has rarely been understood as an agent of public health, sort of trying to limit the sort of both pros and cons of giving access to medications here. They're under limited supply, but also trying to preserve both the health of ongoing, say, patients with lupus and making sure that they have ongoing access to the medications that have been useful and helpful for them for years. Since I'm running out of time, I will say that I did want to ultimately work more with my co-author on this paper, thinking more about what clinical judgment means here, since many of these issues start relying on clinical judgment standards for the pharmacist. They are going to be issues where the bottom set of the slide here, right? Saying clinical judgment requires further reflection on what that even means, saying that pharmacists are being asked to work and make decisions when there's important but missing information or limited information. Rarely this kind of clinical judgment can't be written down as policy to be guiding. So that makes it challenging to teach for the next generation. But modeling best practices may be the most important way to teach junior pharmacists what they should be doing. So with that, I'll sort of end my presentation. Thank you. Sorry about that.